Okay, that's fine. Okay, right. So welcome to the 17th session of teaching. And we have, as far as I remember, we covered hypertension in pregnancy. Remember, children, now all the hypertensive diseases in pregnancy falls into 4 major categories. Okay. There is gestational hypertension, in which hypertension without proteinuria, there is proteinuria without hypertension, and then hypertension with proteinuria, which is preeclampsia. I have taught you all this. I just want you to have an overview. Okay. The second large group is chronic hypertension, right, which may be renal or non-renal causes, which is the second large group which you will meet in pregnancy. The third large group is classified into eclampsia and preeclampsia, that group, right, where specifically eclampsia. And the fourth large group is unclassified. Okay, so where we cannot put it into any of the categories mentioned. So that is the ISSSP classification, International Society for the Study of Hypertension in Pregnancy. So that's an international society. So there is a classification adopted by them. So we generally go with this. Today, we are going to have a look at preeclampsia. Okay. So if you broadly look at these groups of preeclampsia, clinically what we have is we have preeclampsia, we have impending eclampsia, where clinically we think, okay, this woman might have fits, which is eclampsia. Eclampsia, as you know, is eclampsos, that is a Greek word for fits, right? So we have eclampsia. So clinically, sort of we have preeclampsia and eclampsia, right? And preeclampsia, impending eclampsia, and eclampsia. However, there is no specific sort of delineation into each part. Now, what is very important is for you to understand what exactly is preeclampsia, or how do you arrive at a diagnosis or a clinical diagnosis. Now, remember, initially what happens is, the hypothesis or what we think happens is that there is a problem with trophoblastic invasion. Okay, because as you know, the trophoblast or the baby's placenta, the trophoblast, tropho is, as you know, is food, right? Blast is something that divides, right? So it goes on looking for food, right? Which is the placenta for the baby, right? So it needs to invade into the maternal blood vessels to convert the vessels of the uterus into vessels that cannot contract. They should lose their ability to contract, because what happens is, if they retain their ability to contract and constrict according to the wishes of the mother, the baby's placenta is not going to get enough blood. So basically it converts it into just tubes where blood keeps on flowing into the placenta. However, if that fails, if the trophoblastic invasion, if there's a problem with the trophoblastic invasion, so what happens is, the maternal blood vessels will keep their ability to constrict, where the muscle coat has not been properly invaded and changed. What will happen is, the placenta or the fetal-placental unit can become ischemic as time goes on, right? And why does it become ischemic? Because the mother can change its blood flow to the placenta. That is number one. So the whole placental unit becomes inadequate. But why does it not happen initially? Because initially, even if the placental unit is not properly formed, because the growth initially is small, and therefore, and the baby is also small, for therefore whatever the blood that is coming in becomes adequate for the baby. But at some point, usually after 20 weeks, right? The growth demands are such a lot that the growth demands become higher while the placental insufficiency starts to show up. Okay, and therefore then there is a mismatch between the requirement and what the placenta can give the baby, and that causes ischemia to the fetoplacental unit. So it is thought that this ischemia to this fetoplacental unit or a insufficiently or badly formed placenta will produce factors which we do not know. It may be one factor, it may be many, right? Which goes to the body, into the maternal. So it is thought that the placenta is trying to send out signals to the maternal body to try and get more blood. Okay, and these factors will go and harm the entire endothelium. These are endothelial activation factors, which will harm the entire endothelial system of the body and organs. So depending on where these factors will have effect, there are different ways in which the disease will come out in different women. Now, different women or different, because each person is genetically a completely unique individual, there are different defensive mechanisms that are working at different levels in the body, right? For example, in some women, these factors can go and harm the liver cells, where the defense mechanisms may not be very good. However, they may not harm the brain cells. So in these women, because of hepatocellular damage, the liver enzymes will go up. However, this woman might not have fits, which may be because of the brain cell damage, right? Or the edema of the brain. So this woman will have increased liver function tests or increased hepatic enzymes, but she might not have fits. While in another genetically unique individual, these factors can harm the brain cells more, and the brain cell stability or membrane stability may be harmed. But the liver cells may have a good defense mechanism in that particular woman, and therefore her liver enzymes might not go up, but she can have a fit, right? In some women, the liver cells are not damaged because the defense mechanisms are good, but the renal endothelium may get damaged. And if the Bowman's capsule get damaged, the proteins will start to leak out into the urine and we will detect proteinuria. So different women will have different ways and different levels of damage to their systems and organs. And therefore, the clinical picture of preeclampsia can vary widely from woman to woman. You all understand? And therefore, we need to be able to understand the complete spectrum as to how preeclampsia can come up. Now, one of the most commonest factors which we have, right, is normally the arterioles of the periphery are damaged, or the endothelium of the arterioles are normally damaged. And arterioles are the ones that governs the blood pressure due to peripheral resistance, right? And therefore, almost all women, not all, right, almost all, because there may be preeclampsia without hypertension. Almost all women, majority, 90% or so, or even 95% will have hypertension as a clinical feature of preeclampsia. But remember, there is preeclampsia without hypertension as well. Okay, so therefore, we have to remember that, number one. So therefore, hypertension is a common feature. So that is why preeclampsia is secondary. So that is one organ system, right? The peripheral arteriole, the peripheral resistance goes up and the blood pressure goes up. Okay. If there's another organ system that combines into one organ system damage, we call it preeclampsia. So isolated hypertension is not preeclampsia. So it is gestational hypertension. Isolated proteinuria, say if the factors go damage the Bowman's capsule and the protein comes out, is not preeclampsia. However, the combination of hypertension with another organ damage is called preeclampsia. Okay. So if there are two or more organ systems involved, it is safe for us to call that preeclampsia, right? And therefore, there are specific other syndromes that has been derived from this. Sometimes called a severe form, like HELP syndrome. HELP syndrome has what? It has hemolysis, low platelets, and elevated liver enzymes. Okay, where hypertension does not play a role here. Okay, although hypertension also might be there as well. You all understand? So any two organ systems involved, right? And that we can diagnose that patient is having preeclampsia. Now, preeclampsia is something, it's like a vehicle put on top of a mountain without brakes. Okay, and it goes down. It never reverses back, right? You don't have a reverse to preeclampsia. So if you diagnose it, that patient probably needs to be involved. So if you have hypertension without proteinuria or without any other organ involved, then it's just hypertension in pregnancy, which can be managed at home if it is adequately controlled. However, if you have a woman with hypertension and proteinuria, or hypertension with elevated liver enzymes, right, or hypertension with low platelets, right, any other organ involvement, that patient needs to be involved as an inpatient, because she can go from there to impending eclampsia or directly to eclampsia, right? So therefore, remember that for life. Okay. Now, let us look at how these things come out, right? How do we find whether other organs are involved in preeclampsia? And what are the investigations and the clinical signs and symptoms that we can look into to diagnose preeclampsia? Okay. Number one, as I told you, the commonest is hypertension. Okay. And as you all know, right, anything over 140 and 90 is high blood pressure in pregnancy. Okay. Very severe high blood pressure is anything over 160 by 110. Okay. So that is hypertension. So that is number one. Usually, how is it checked? The blood pressure monitoring device. Normally, a mercury sphygmomanometer is the best because it gives us the least variations, while electronic blood pressure measuring device may not give us a proper reading. Number one. Number two, the cuff size is also very important. If the cuff size is smaller than the arm or larger than the arm, then you can have problems with the diagnosis. So the cuff size needs to be proper and adequate for that particular patient, right? So therefore, then that is hypertension. Okay, and that of course you all are very good at measuring, hopefully, right? Then comes the second part. How do we diagnose proteinuria? Now, proteinuria, remember, the Bowman's capsule allows a small amount of proteins, right, which are due to the pores in it, and the sizes are small and they get reabsorbed, and we hardly or do not have much protein in the urine. But if the Bowman's capsule is damaged, larger proteins will start to leak out, and then it won't be reabsorbed and it will go out from the urine. So one of the easiest way is a reagent strip. We hardly ever boil urine now, so it's a reagent strip, right? So it can give us plan plus 2, so you can put it in a check. The best way, or one of the best ways, would be to take 24-hour urine. 24-hour collection of urine for proteins, right? And how is it done? A woman is asked to pass urine. Then she starts collecting her urine into a large jar, right? And then 24 hours later, she empties the bladder into it, and you have a huge bottle of urine, right? And then that is sent to the lab. What do they do? So they do a kalavama and they get a small sample and measure the 24-hour urine albumin, okay, protein. So what is the cutoff of 300 milligrams in 24 hours? Is a significant amount of protein that is there. So, and that is considered significant, right? 1 gram is quite high. It is equal to almost 3 pluses of urine in a reagent stream. Okay, so that is number 1. The other bedside test, which has a very high sensitivity and almost a 99% positive predictive value, right? Which equals the renal excretion of protein, right? Which really does not vary with the time that is collected as well, is the urine creatinine albumin ratio, right? Which is a very good test, and that will also indicate, and we can take that actually without trying to collect the, although perfectly we should do a 24-hour collection, but as a good test, right, with a good sensitivity, almost 92%, good specificity, about 94%, good positive predictive value of 99%, right? So it's a very good test actually, which you can use to predict the amount of albumin or proteins loss, right? So therefore, these are the ways in which we diagnose protein loss in pregnancy. So we have now got 1, hypertension, which we measure. 2, we have loss of protein. Okay. The third, I'm mixing all the signs and symptoms together. Okay, so that you all understand. Okay, signs are what we discover. Okay, symptoms are what the patient is going to tell us. Now, when this factor damages the brain, what happens? What does the woman have? What she has, or clinically, she can have severe headache. That is number 1. 2, because the center for sight is in the brain. Okay, it's behind. Okay, and it can cause visual disturbances, and especially if there is retinal edema, right? And there is edema of the brain as well. The membranes or brain cell membranes are not stable, right? And therefore, you can have visual disturbances, which may be different kinds of lights going around. She will tell you that different dark spots are going around. Scotoma, some vision, the field, some places may be lost, right? And then she might not be seeing things properly. So those are all visual disturbances. Then flashes of light, all sorts of different visual disturbances might be there in severe preeclampsia and impending eclampsia. Okay. Also severe headache, and that also will cause her to vomit, right? So vomiting, severe headache, nausea, right? Visual disturbances can be part and parcel of impending eclampsia due to the fact that the brain cell membranes are damaged due to whatever circulating factor that activates the endothelial lining of the brain cells, right? So that is the next step. Then we go on to the other organ, right? So we have covered the brain, we have covered the whole system that causes hypertension. Then we have covered the kidney, right? And therefore, next we will go on to the bone marrow. In the bone marrow, the damage to these, right, into the bone marrow will cause damage to the mother cells that produces platelets, which are what? Megakaryocytes, right? And that causes a reduction in the platelet. That is number 1. The second thing is the universal endothelial cell activation will cause coagulopathy, right? It can cause disseminated intravascular coagulopathy. It can cause consumptive coagulopathy, right? Because of the endothelial, there can be microthrombosis everywhere, right? And therefore the platelets will be consumed and the platelets will drop, right? A drop in platelet level, especially if it was 180, 60, and then it drops to 150, 120, 120, then going down to 100, and so on and so forth, is a very bad sign, which might make you consider delivery. Okay. Usually anything more than 50, 10 to the power 9 per liter is okay as far as the coagulation is concerned. However, a drop in level below 100, say, starts to drop rapidly, is a very, very big danger sign. And usually for anesthetists, they require something over 70 or 80, 10 to the power 9 per liter, right, of platelets to give a regional block. So therefore, drop in platelets, not necessarily an immediate one, but anything that is dropping, right, is not a very good sign for us, where there is mass endothelial cell activation with consumptive coagulopathy, with disseminated intravascular coagulation, should ring all the alarm bells that you have in your heads. Okay, so that is the platelets. Now, the next part. If the platelets drop below 100, right, or it's dropping, one of the things you will need to do is to think there may be coagulation problems, right? Therefore, we need to do in these patients, look at the coagulative mechanisms. And what are these? How do you look at this? We basically do a PT, prothrombin prime, to look at the extrinsic pathway, and we do a APTT to look at the intrinsic pathway. So that investigative line should be triggered to look at the coagulative pathway, and if necessary, if there are specialized ways in your hospital to look at the coagulation area, the defects are, you might look at those as well. There are specific machines which can do that, and we might need to treat those patients specifically in conjunction with a hematologist or a transfusion medicine specialist to try and correct these coagulative defects which we find. Okay, so that is that. Then one of the most dangerous things that we find is what? In preeclampsia and eclampsia, the biggest problem is that all the vessels leak, because there is universal endothelial damage, and all the vessels have holes in them, right? And what do these holes do? The proteins leak out of the blood vessels. When the proteins leak out, because the proteins consist, or what they do is, they increase the oncotic pressure of the vessels, which keeps the fluids in. So when the proteins go out, the fluid follows it, and there is intravascular depletion of the fluid levels. And in the interstitia, the fluid levels go up. So if we do a hematocrit, what happens? Hematocrit, the blood concentration increases, and therefore the hematocrit increases. So if you are monitoring a patient with preeclampsia, and we find a hematocrit of, say, 38 or 39 today, and then tomorrow or in the evening we find it 42, 43, 44, we are really looking at trouble. Okay, there is depletion of intravascular fluid. Why? Because all the vessels are leaking, all the proteins have gone on to the interstitia. There is very much concentrated blood intravascularly, and that is going to give us trouble, because with that, the coagulation also will increase, thrombosis will also increase, and the complications will go up. Okay, so that is that. Now, biggest problem of why women die are two things. Number one is pulmonary edema. And how does that happen? Usually iatrogenic, us. When the vessels leak, the interstitia, the blood vessels, when the blood vessels leak, all the proteins will go out into the pulmonary interstitia as well. And therefore, literally, the woman drowns, right? And if we pump in fluid, on top of that, pulmonary edema will increase. And therefore, that is pulmonary edema, or iatrogenic pulmonary edema, is one of the causes that can cause death to a woman with preeclampsia or severe preeclampsia, right? And therefore, this is the time when we monitor. It is very important for us to have a CVP line, right? And anything over 8 millimeters mercury, right? We should not be transfusing fluid, or we should be very, very, very careful when we transfuse fluid. Otherwise, we will cause pulmonary edema. Okay. So we need to be very careful if there is oliguria, and we should not be giving continued boluses of fluid challenges without a CVP line. Okay. By this time, of course, the patient would be in the ICU, managed by our very competent anesthetist, right? And therefore, definitely they will have a CVP line in, right? And if the pulmonary pressures are high, we have to be very, very, very careful with the fluid burst. And if worse come to the worst, they will do, you can do a pulmonary artery catheterization, which can also measure the problems there. And that also can be done with our very competent anesthetist and the ICUs, right? So therefore, that is, we have to be very, very, very careful about fluid. Remember, when we are giving fluid, which I will speak later, it is always, we try to manage with the complete input of 1 ml per kg per hour. We restrict fluids, right? And therefore, we try to make sure that we do not overwhelm her with fluid. Remember, oliguria is about, from an obstetrician's point of view, is about 400 ml of urine output in 24 hours. Anything more than that, more than 400, we don't really need to worry, and we don't need to treat. Okay. If the urine output falls and she is oliguric, right, we must not be pumping in fluid. We need to be very, very, very careful in the amount of fluid which we give, right? If the urine output is low, right, if the CVP pressures are high, we should not be pumping in fluid. And then what we can do is we can add a bit of dopamine to increase the renal perfusion, usually 1 microgram per kg per minute, right? So that is done. You need to be aware. If the potassium and the other things go up, right, in these patients, sometimes they might need hemodialysis or other forms of sorting it out. So there are a renal physician's input will be required at that point, right? So these are, but I will speak about fluid later as to how we manage it. But remember, this is what we do for that type of manage, right? So now I have spoken about the overall endothelial damage. Now what will happen? How do we look at it? Hematocrit. We look at the hematocrit in the full blood count, and we also look at the platelet count in the full blood count, right? Is that clear? Right. So these are the organs. Now next, let's look at the liver. If the liver cells get damaged, right, there's hepatocellular damage, the AST will go up, right? And anything over 50 is not a very good sign. The cutoff mark in pregnancy is about 20% less than the normal cutoff mark. So we take the AST levels cutoff mark at 35. If it is going over 50, right, we are looking at trouble, right? So remember, 50, and so therefore we need to be very clear. The other thing is, when there is hepatocellular damage, right, the liver enzymes will go up. At the same time, there can be under the capsule of the liver, which is called the Glisson's capsule. Remember, the liver has no nerve cells inside. It's only the capsule that is sensitive, right? And therefore, what happens is, if there is microthrombosis of the capsule due to intravascular coagulation, right, there will be ischemia of the Glisson's capsule, and that will cause severe pain. And where does the pain occur? In the epigastric region. Okay. If there is bleeding under the capsule, that is called subcapsular hemorrhage of the liver due to the rupture of the vessels, right, in preeclampsia, that can cause a massive bleed there, and the women will have severe hemorrhage there, and it can cause death. The other time, because there can be subcapsular hemorrhage, the capsule can rupture and she can have massive hemorrhage in the abdomen from which she can die. So these are the problems that can occur with preeclampsia. And clinically, how is it? She has severe tenderness, right, and pain in the epigastric region, right? So that is number. Remember, women die of two things. Number one, intracerebral hemorrhage. Number two, pulmonary edema. Those are the two killers of preeclampsia and eclampsia in women. So most of our management in preeclamptic patients are concentrated on two factors. Number one is to try and avoid pulmonary edema, right, by managing the patient properly. And second, to try and reduce the blood pressures to prevent intracerebral hemorrhage, right? So this is the general understanding that you have to have. Okay, right. Now, so we looked at the symptoms as to how preeclampsia can happen and impending eclampsia can happen. We looked at the organs that are damaged. We looked at the mechanisms that are damaged. And we also looked at the same time, how we are going to diagnose them. Okay. So any questions so far?
No, sir.
No, sir.
Oh, beautiful. Okay, right. So nice. So this is now there are several things I need to speak to you about. Number one, the importance of uric acid. Not important at all. Okay. Uric acid can be hugely elevated in fatty liver of pregnancy, right? But usually it does not give us a very, what it is, clinically it does not, early it was thought that, but clinically it does not give us a very good understanding of what the developmental disease. That is number one. Number two, remember creatinine and renal profiles, right, are not very useful, because creatinine and those are end-stage renal failures do not occur in preeclampsia and impending eclampsia because it progresses very quickly. Okay, there's no time for the creatinine to go up, right? So please remember that creatinine and blood ureas and all that are not very important as for us to manage immediately impending preeclampsia and impending eclampsia. So we hard labor, we can do it. But if creatinine is rising, so especially, we have to think there may be some other problems associated with the problems, and therefore we might need to also, we of course will have to get a renal physician involved in looking at these problems as well, right? So if you look at the summary, and if you are going to look at preeclampsia and how to diagnose it and how to look at the intensity or how big the problem is, the investigations that we have to do, remember, are these. Brain problems, normally EEGs and all that are focus we don't do, but there's something which you have to understand. If the woman keeps on fitting and is having eclampsia, you have to check for infarction and intracerebral hemorrhage, otherwise the woman can die, right? Even if it is not controlled with our magnesium sulfate, definitely we need to do a CT or MRI of the brain. Please don't forget that. So signs are what? Signs or symptoms. The woman can have severe headache, nausea, vomiting, visual disturbances that is scotomata, flashes of light, also, and haziness of vision, blurring of vision, all that are cerebral involvement in preeclampsia and cerebral edema, right? And if you do look at the funda, you can see the edema as well. Two, you look at the full blood count, that will show you the depleting platelet count. That is normally due to consumptive coagulopathy, and endothelial, massive endothelial activation everywhere in the body, right? You look at the hematocrit, that will show hemo concentration. You do not give furosemide to increase the urine output in a woman who is having preeclampsia, because that will deplete the intravascular blood more and cause more severe problems, right? The only place for furosemide is if the woman is having pulmonary edema, and to control that. Remember that, please. Okay. Next, so we look at the hematocrit to look at the hemo concentration, right? And then, of course, we can look at the protein levels in her. So she will have hypoproteinemia or hypoalbuminemia if she is losing protein. So we can look at those as well. Liver, I told you, she can, if you do a scan, sometimes you can see the liver capsule, subcapsular hemorrhages. Of course, the scan will show us if she has a massive rupture. Of course, she'll deteriorate very quickly and she can die very quickly, right? And there'll be severe tenderness in the epigastric period, because when you will press onto the Glissen's capsule, which can cause pain, and microthrombosis of the capsule also can cause pain. So you have epigastric tenderness, epigastric pain, right? And the other forms are very rare, right? Like capsule rupture and hemorrhage, but still those are very, very severe problems. So that is the liver. And of course, the AST will go up. Anything over 35 is elevated. If it is going over 50, we are really looking at trouble, right? And that should give us all the alarm bells to sort of deal with the patient, okay? Then comes the kidney, okay? As I told you, creatinine, blood urea, there's no time for those to go up. What we are looking at is, if you are looking at it, is we are looking at the protein loss. And how do you look at it? Either a 24-hour collection with proteinuria, or its easier test is a creatinine albumin ratio, which has a good sensitivity, specificity, and a positive and a negative predictive value, which can tell us the approximate amount. There's a good correlation with the 24-hour protein loss, and that can give us a very good idea as to what is happening. Dipstick, 2 or 3 pluses can be there, but that is also a way of looking at the kidney, right? Remember, creatinine, all those are not useful for us in this parents. So that is what you have to remember. So that gives you an overall impression as to what needs to be done to diagnose and what needs to be done for the monitoring of preeclampsia. So more severe the patient is, we repeat these investigations at more frequent intervals. For example, if the disease is very severe, we might need to repeat it morning and evening in an ICU or HDU. If it is not so, maybe daily, right? So daily you can repeat it. You all understand? So we need to monitor the woman to check for the, and of course the baby. What are the problems with the baby? Bad placentation is small for gestational age, or the baby. What can happen to the other thing? They can have small for gestational age, where the baby can die due to placental insufficiency. The baby can have intrauterine fetal death, right? That is the third thing. And the other thing that can happen in eclampsia and impending eclampsia is, due to bad placentation, is abruption of the placenta. So those are the 3 things that can happen to the baby: intrauterine death, abruption, and intrauterine growth restriction with, well, death. It can continue to death. You all understand? So those are the 3 things that can happen to the baby. The 2 things, bad things that can happen to the mother, what? She can have intracerebral hemorrhage and die. She can have, the second thing is pulmonary edema and can die. Plus the other things, of course, very rare, like capsule rupture. Those are very, very rare, but also death can occur with those, right? So do you all have an overall view as to how to manage these patients? Now, let's look at each individual principle of managing preeclampsia as well as impending eclampsia as well as eclampsia. Okay. The first principle, what you have to understand is, where do we, especially intrapartum, we need to decide whether we need to deliver. The answer to all these problems is delivery. Okay, the baby comes out, the placenta goes out, right, and problem should settle, right? However, you have to remember that all this hypertension that comes in the latter part, like 36 weeks, 37 weeks, hardly ever, usually, unless it was undiagnosed, hardly ever progresses on to impending eclampsia and eclampsia. The ones that come early on, like at 22, 23, 24 weeks, are the ones that will progress to preeclampsia, impending eclampsia, eclampsia, and problems, right? So those are the ones we need to manage. There is only one principal, children, in the management of these patients. So look at it like two railroads, right? Going this way, parallel to each other. And what are these main things? One thing is the mother, and the other thing is the baby. Okay? So the principle is, whenever we think that the mother is in danger, regardless of the baby, whatever period of gestation, we deliver. If the mother is not in danger, but we continue, since we continue to monitor the fetus, and at any point, if the fetus is going to die, we deliver. Okay? So that is the principle. So the principle is, we monitor the mother and we monitor the fetus in these women. That is the simple principle behind all this. Okay? The mother, if she is deteriorating, and we think that she's all her biochemical signs, all her clinical signs, all this, signs, symptoms, biochemistry, everything, if it is going badly, then we deliver without endangering the mother. Okay? If the fetus, when you are looking at it, if there's an abruption, the baby can die. The mother also can die due to DIC, right? So then we'll have to deliver. If the baby is having small for gestational age, and then we continue to monitor, and if the CTG becomes, when it shows fetal distress, or if the Dopplers tell us that there is a absence of diastolic flow, or a reduction or a reversal, we need to deliver. Remember, Doppler, I will speak to you about Doppler in it. It's simply, remember that the placenta is a low resistance system. The only pump that works is the baby's heart. Okay? So the baby's heart pumps, the blood goes onto the baby's body, goes onto the internal ilex, through the umbilical arteries, it goes through the placenta, and there's a low system, the exchange takes place in the placenta. The umbilical vein comes back to the baby and brings the blood to the baby's heart, and again it pumps. Okay, so the umbilical cord carries two arteries, because blood is carried away from the heart to the placenta, and it carries one way. Okay, that brings the oxygenated blood back. Now, this whole system functions only because the heart is pumping, the baby's heart is pumping. Okay, so therefore the blood to go this complete round through the placenta and come back, the placenta needs to be a low resistance system. You can't have resistance there, because the blood must come back to the baby, otherwise the baby is going to die, right? So what do we do with Dopplers? When the baby pumps, the systole, the blood is moving forward. And of course, the blood has to move forward in the umbilical arteries or the cord. Otherwise, what? The baby will die. So it goes through the placenta and comes back. So during the systole, we will see a forward movement of the blood. Okay. However, the diastole is passive. Nobody is pumping anything. So it just goes along with the power given to it by the heart or the systole. However, if there's resistance in the placenta, what happens is, when you look at the Doppler in the umbilical cord, the diastolic flow will drop because of the resistance. In the even worse cases, the diastolic will be absent, because in the systole it will go through anyway, otherwise the baby is going to die. In the diastole, it stops because there is resistance in the placenta. Then a systole, again it will pump. Okay. And then if it becomes even worse, during the diastole, the blood will go there and come back. It will reverse. So that is reversal of the diastolic flow. You are looking at a high resistance system in the placenta, and therefore the baby probably is going to die within 24 hours. So that is how you monitor the baby. So you can look at the Dopplers to see the baby. If there is not much perfusion of the reins of the baby or the kidneys of the baby will not urinate a lot. So therefore you will have oligohydramnios, you can have bad CTGs, you can have reversal or absence of diastole, in which case you might want to deliver. So the principle behind managing these cases is the mother's life is in danger, you deliver. If the baby's life is in danger, you deliver. Right? You all understand? So it's simple as that. Now, what do we do for the baby? If the baby is having problems, what we do for the baby is that we try two things. Number one, we try to get the fetal maturity, lung maturity, because that is why the babies die most often. And what do we give? We give maternal steroids to increase fetal lung maturity. As you all know, we give what? Steroids. It can be dexamethasone, right? 12 milligrams twice daily to accumulate in dose of 24 milligrams, or we can give betamethasone 60 milligrams twice daily if there's time, 4 doses, right? That is the best to accumulate dose of 24. So those are the two steroids used. You can use hydrocortisone, but you have to give a huge dose for it to go across the placenta, which we don't use, right? And the rest of the steroids are not very good for to increase fetal lung maturity. What do these steroids do? They go and have an effect on the pneumocyte type 2, which will increase surfactant, right? Which will increase the surface tension, which will increase the lung maturity, right? And therefore, the maximum peak time it works is about 48 to 72 hours, and then gradually drops to about 1 week later. Okay. So these are the second thing. If the baby is going to be born before 32 weeks, magnesium sulfate is really important, even if the woman is not having severe preeclampsia where there is no indication for magnesium sulfate. But for neuroprotection of the baby, maternal magnesium sulfate is indicated in the normal eclampsia or preeclampsia doses which we use. What does magnesium sulfate do? It goes to the baby. There are several things it does. Number one, it's a membrane stabilizer. It stabilizes the brain membranes, right? Second thing, it reduces the ischemic damage to the brain, right? So there is neuroprotection. And that is why at the same time, in the mother, in the brain, right, it can reduce, because it stabilizes the membranes, it reduces the shooting of the action potentials, and therefore it will reduce the excitability of the brain. It will also reduce the edema, and it will reduce the fits. Okay. For the baby, it gives neuroprotection. So any baby delivered before 32 weeks, we need to give magnesium sulfate to the mother for the neuroprotection of the baby. So those are the two things that we can do. If she is having preeclampsia and impending eclampsia, anyway, we are going to give you max sulfate, and therefore the baby will automatically get neuroprotection anyway. You all understand? Right. So those are the two things we do for the baby. If, of course, the monitoring, which I told you about, which we need to continue. Right. Now, let's look at the mother. Okay. If you are going to look at the mother, there are several principles. Remember, I told you the principles are what? Why do the mothers die? It's because of hypertension plus problems with the coagulation, which can cause intracerebral hemorrhage, and the women die. What is the second cause? Because of the leakage due to the endothelial damage of the pulmonary blood vessels, they die by pulmonary hypertension or drowning, basically, right? So we basically aim at these two. So for that, we try to control blood pressure. The second thing is we try to control, or we very, very, very carefully monitor the fluid or fluid intake, output, all that, or the fluid management. So the very first principle in the management of women with preeclampsia is the management of hypertension. Okay. So any woman who is having severe hypertension, right, needs to be managed to prevent cerebral damage. So it is found that if you reduce the blood pressure to a certain amount, you can reduce the amount of cerebrovascular accidents. However, we are really not doing a favor to the baby at all. You reduce the blood pressure, it will reduce the placental blood flow, and the blood flow to the baby is going to be reduced somehow, because it is the baby and the placenta that is trying to get more blood. It doesn't really care the mother, because it works like a parasite. So it increases the mother's blood pressure by putting out all the factors it can. Okay, so with hypertension it gets more blood. However, what we do is to try and save the mother, we reduce the blood pressure. So perfusion becomes less and the baby is going to suffer. But here we are worried about the mother's life initially, right? Now, it has been found that just by looking at the blood pressure, like, okay, 160 by 110, 190 by 120, what is more clinically relative, or sorry, more clinically better is to try and look at the mean arterial pressure. What is the mean arterial pressure? We take into consideration the diastolic as well as the systolic, right? And how do you talk about mean arterial pressure? It is the diastolic plus 1/3 of the systolic diastolic difference, right? Or the pulse pressure, right? Now, how do you say that? Say if it is 190 by 120, the diastolic is 120. The difference between the diastolic and the systolic is 70. So you divide by 3. So that is about, say, 22 or something, right? I hope so, yeah. 22, 20, yeah, 22, 23, right? And then you add that with the diastolic, so you get 143, yeah, 143. So any MAP or mean arterial pressure over 125, it is thought that intravenous antihypertensive agents are indicated. Till then, you try to go with your normal antihypertensive, which I have spoken at length. So we need to give intravenous antihypertensive agents. The first agent, the agent of choice is labetalol. The second agent which you have to use is hydrolysine. Third and fourth agents, nitroprusside and nitroglycerin, those are not very used, but the first two agents we need to know very well. So how do we look at it? If the mean arterial pressure is over 125, what we do is we give a bolus. One moment, sorry. Hold on. Okay, children, where were we? Fatima Zaina, where were we?
So we give bolus if the MAP
right,
is
okay,
more than
right,
120.
okay. So, yeah. So intravenous antihypertensives are indicated if the mean arterial pressure goes over 125. Okay, till then we don't need to care. So if the mean arterial pressure is over 125, what we do is we try to get it down, not because we like the baby, because we are not doing a favor to the baby, but we don't want the mother to die. Okay. So the first drug of choice, I told you, right, is labetalol, and then we go with hydrolysine. So there are protocols, they are different, but the most commonest protocol which we use is labetalol. We need to give 20 milligrams intravenous as an initial dose. Then we check the blood pressure in 10 minutes. Okay. And then if the mean arterial pressure is still over 125, we give 40 milligrams again. Then we make the pressure in another 10 minutes. And if it is still over 125, we give 80 milligrams, right? And then we keep on repeating 80 milligram boluses until we have a cumulative dose of 220 milligrams. Okay, is that clear? 10 minutes later, you measure the MAP. If it is below that, then you look wait like that. If not, then you give another 40, then another 80, right? And then you give another 80, right? Every 10 minutes if the MAP still remains high until a cumulative dose of 220 milligrams have been reached. So you stop at any time where the MAP is below 125, okay? And then you need to start an IV dose to continue, right? And you can start on 40 milligrams IV per hour, right? Or 80 and so on and so forth until you can go up to about 160 milligrams per hour, right? You all understand? So that is the maintenance dose, okay? If labetalol doesn't help, you can sometimes switch on to hydralazine, or you can give hydralazine as well, because sometimes in most hospitals we will not have labetalol. So what is the protocol for hydralazine? It is an arterial dilator, right? And hydralazine, we give first 5 milligrams and then we measure the blood pressure in 15 minutes. 5 minutes, sorry, 5 minutes. Then if the MAP is still over 125, then we give another 5 minutes. Then again, we give another 5 minutes. So we can give up to 15 milligrams in 15 minutes. Okay. And then that is the maximum. After that, we need to keep it on a, we have to go on with a maintenance dose, right? And how do you do the maintenance dose? You start with 10 milligrams per hour of hydrazine, and every 30 minutes, you can increase it to 20. And then either you can put in 30 milligrams per hour or you can go to 40 milligrams per hour. The maximum is 40 milligrams per hour, right? That is the maintenance dose, right? So those are the two protocols that you need to have in mind, right? And which can be used to control acute hypertension in preeclampsia and impending eclampsia. Is that clear, children? Right? The other drugs we hardly ever use, right? So these are the two drugs that you need to know. Okay? Then, so that is all about hypertension, which we need to understand at your level. The second large principle is, now the first large principle is the control of hypertension. Clear? The second large principle is fluid management, right? As I told you how important it is, the most important thing about fluid management, children, is what? Do not overload. And so what is our normal thing? We try to give the minimum amount of fluid, and that we keep it at about 1 ml per kg per hour. And sometimes we drop it as low as 50 ml per hour in some patients. So for a 50-60 kilogram patient, we do it at 50 ml per hour. Normally, it is 1 ml per kilogram per hour. Okay, that is the minimum which we give, so that her bodily functions will be okay, right? What is oliguria? Less than 400 milligrams milliliters per 21. If it is less than 40, over 400 milliliters in 24 hours, we really don't need to worry. If it is less than that, we can consider it as oliguria. Remember, do not, if the urine output is less, we try not to give fluid boluses. If you think that fluid boluses are necessary, right, to safeguard the kidney, you have to make sure that a CVP line is in, right? And the CVP line will look at the central venous pressure. Anything over 8 millimeters mercury, we are looking at pulmonary hypertension, right? So you'll be very, very, very careful about the fluid that you give, because we can cause iatrogenic pulmonary edema, which can cause death, right? The only instance where we give furosemide, remember, right, is if there is pulmonary edema. Otherwise, we don't use it, right? In that case, if still the woman is oliguric, then to increase the renal flow, we can give dopamine 1 microgram per kg per minute, right, to increase the renal blood flow if necessary. If the potassium is going up, if the renal functions are deteriorating, if the creatinine is going up, right, we do not give fluid boluses. We speak with the renal physician and try and get them into hemodialysis to save a life. Okay? So that is how you manage fluid. What is the principle? The less, the minimum is the standard. we try to give the minimum amount of fluid, avoiding iatrogenic pulmonary edema that can cause death. Okay, so that is the fluid management. The third most important principle of management is the management of fits and the prevention of fits. Management of fits is laid out in the eclampsia trial. Prevention of fits is laid out, or we got the information from the magpie trial. Okay, those are the two trials that you will want to think about. If the woman is fitting, remember diazepam, phenytoin, those are second line drugs. We really don't use them. The drug of choice, right, which we use is magnesium sulfate. So I told you magnesium sulfate, it stabilizes the brain cell membranes, right? It reduces pulmonary edema, reduces the action potentials, and reduces fits. And magnesium sulfate, it is thought, has the potential to cut down 50% of eclampsia, and therefore probably prevents death as well. Okay, so when the trial was used against placebo, and it cut down fits by cuts down, it prevents about 50% of eclamptic fits. However, to treat eclampsia, magnesium sulfate is also used, and therefore that is also very, very important to treat the fit with magnesium sulfate, which is the drug of choice. Now remember, children, magnesium sulfate comes in different kinds of vials, sometimes different kinds of containers, right? First of all, children, the amount of magnesium sulfate we need to give intravenous is 4 grams. Okay, 4 grams of mag sulfate. Now, when the woman is, if the woman is fitting, right, you can't give mag sulfate. Usually eclamptic fits are self-limiting. If they are not self-limiting, you really need to at some point do an MRI or a CT, because it might be intravascular hemorrhage, intracerebral hemorrhage. Okay, right. So therefore, you do not try to insert cannulas and do this and that everything when the woman is fitting, and you do not try to lift the woman off the floor and you are trying to get them when the woman is fitting, because she will fall and she will have trauma, right? Wherever she is, just safeguard her, turn her over to the side so she does not choke, right? But wait until the fit is over. Then you can put in your cannulas, right? Clear the airways, get her onto a bed if necessary, right? Suck out the secretions and manage her. And we have cited the IV cannula, children. Then you go with 4 grams of magnesium sulfate. Remember, one of those vials, different types, just look at the percentage first. You need to be aware of the vials which you have. So there may be 25% magnesium sulfate, there may be 50% magnesium sulfate. What does that mean? It basically means in 1 ml, which is 1 gram, there's a half a gram of mag sulfate if it is a 50% vial. Do you all understand? If it is a 25%, in 1 ml, there will be quarter gram of mag sulfate. So usually we get 50% volume to mag sulfate, okay? Which means every milliliter will have a half a gram of mag sulfate. What does that mean? So you have to take 8 milliliters to get 4 grams of mag sulfate. Remember that, children, for life. Is that clear? That is how you anyway calculate, right? And then you put this 8 ml into 100 or 200 ml of normal saline, right? And then you let the drip go into the woman over 20 to 30 minutes. You don't just inject it, okay? And that will reduce the fits. If she is still fitting, you can repeat the dose and you can give up to 8 grams, okay? 8 grams of mag sulfate, right? If she is still fitting, either you have to take her to the theater and anesthetize her, a general anesthetic. But the general anesthetic is dangerous, right? Because it can cause intubation, can cause severe hypertension again, right? However, sometimes the only way to control the fits may be general anesthesia, okay? However, at the same time, she's still fitting on, right? You really need to think about intracerebral accidents which you need to, and otherwise she can die. Okay. So when you, after you have controlled the fits, yes, you can think of phenytoin and diazepam, but they have, the effects will be longer and it is not that effective in eclampsia. Okay. After you have done that, then you continue the Maxalf with the infusion pump at 1 to 2 grams per hour. And that is how you continue that until the delivery has been made and another 24 hours after postpartum. So that is how you use magnesium sulfate, right? So the continuation of the infusion is for the prevention of fits. So in a woman who has had fits or eclampsia, you can use magnesium sulfate to stop the fits. And then you continue the magnesium sulfate. The second instance which we use magnesium sulfate, children, is what? Is to prevent fits happening even if they have not happened. So if the woman is having signs of impending eclampsia, which you have diagnosed, which is scotomata, visual disturbances, severe headache, vomiting, all the biochemical functions are going through the roof, you have epigastric pain, right? So, and she is disturbed, the hypertension is not getting controlled, you are looking at a bad picture, and then you know she's going to fit, and therefore you use magnesium sulfate to prevent fits. And the protocol is exactly the same. 4 grams slow intravenous for 20 to 30 minutes. Then you can, then you continue for 1 to 2 grams per hour until delivery and after delivery as well to prevent the fits, because postpartum, 1/3 of the fits are postpartum, right? And therefore you need to continue the Maxalf 24 hours after delivery or 24 hours after the last fit. Okay. So that is magnesium sulfate and its place in prevention of preeclampsia and its place in eclampsia. Is that clear, children? Right? So that is magnesium sulfate. So we have considered the 3 basically or 4 principles of managing a woman with impending eclampsia and severe preeclampsia. Okay, what are these? Management of the baby, which we discussed. We discussed the investigative process and the monitoring process. Then we discussed the management of hypertension, acute hypertension, and we discussed the prevention of fits and treatment of fits, and we discussed the fluid management of these patients. Do you all understand? So these are the 5 basic principles that you need to understand to try and manage these patients. Okay. Once she is delivered, because delivery is the only thing. Remember, if the platelets are below 80, then the anesthesia, right? If we have wonderful anesthetists, right? So if the platelets are below 80,000, right, regional anesthesia may be a problem, right? And therefore, we sometimes need to transfuse platelets for regional anesthesia acutely to get a regional anesthetic in. But the safest is always regional anesthesia. Okay. General anesthesia we try to avoid because intubation will cause an increase in hypertension in these patients. However, if she's continuously fitting, we have no option. So they will do the general anesthetic. Okay. The next is, that is anesthesia. Next is, of course, postpartum. We need to continue to monitor these women postpartum. Okay. She probably needs to be in a high dependency unit or ICU. All the monitoring needs to take place, right? The blood pressure needs to be monitored. The renal functions need to be monitored. All the rest of the biochemical tests need to be monitored. The magnesium sulfate needs to be continued for 24 hours after the last fit or after delivery, right? And those are the, she needs to be under. So usually 24 to 48 hours later, the chances of her having a fit is very, very small. So first 24 hours after delivery, 1/3 of the fits will happen or eclampsia will happen after delivery. 2/3 before and during delivery. Okay, so therefore we need to be, she needs to be under very, very good monitoring postpartum. Okay. And what about the future? How do you talk to them? So they need to be monitored. Antihypertensives need to be considered. So, and if the hypertension continues beyond 6 weeks, of course, she will need to be referred to a physician for delivery. And of course, there are several things we need to learn. If a woman has preeclampsia and eclampsia in pregnancy, she has a 6-fold increase in developing chronic hypertension in the future. She has a 4-fold risk of developing cardiovascular accidents in the future, right? And 4-fold increase in having thromboembolic problems in the future. Okay, and cerebral infarctions of the brain, 2 to 4-fold increase in the future. So these all needs to be under. And of course, if this continues, she will need to be checked for other problems that can cause, like problems with coagulation, like syndromes which might cause increase in coagulation, right? And phospholipid antibody syndromes, autoimmune diseases. These the physicians will check if she has had preeclampsia and liver. So therefore, these are the things that you need to tell the woman, right, to be on the lookout for, right? So this basically, I think, covers preeclampsia, impending eclampsia, and eclampsia, and what is done afterwards. Yeah. Okay. I think we have any questions, children? Okay, there are 2 questions. You can type it in. Is Magsalf used to prevent or treat fits? Should it be given to patients with preeclampsia? Yeah. So that is, I answered that question. I think the question must have come before I said. One of the things which is one principle is the treatment of fits. The other principle is the prevention of fits. So use it for both. So any patient who is having severe preeclampsia and intermittent eclampsia with the fits, without the fits, you give Magsalf. If she's having fits, you give Magsalf. Right? So that is the same. Is there a neuroprotection for fetus by Magsalf? I think I answered that question as well. Remember that any baby delivered before 32 weeks, right? Even if there is no preeclampsia, right, and we are delivering for a different purpose, we still give magnesium sulfate for neuroprotection of the fetus. So the best effect of neuroprotection will happen less than 32 weeks. After 32 weeks, a bit controversial. So you may or may not give, but less than 32 weeks, definitely if you are delivering a preterm fetus, Magsalf is indicated. Not for preeclampsia, but for fetal neuroprotection. But anyway, if it is preeclampsia and eclampsia and we are delivering, since we are giving Magsalf, the neuroprotection for the baby is already automatically there. Okay. Is it a must to, next question, is it a must to deliver baby after Magsalf, or can we wait if symptoms settles? It's highly unlikely for the symptoms to settle. So we should not be playing a huge waiting game, right? It's a very controversial topic which you brought out, right? So there are some people who will wait, but you know, if you have started with a protocol of managing severe preeclampsia and impending eclampsia, you are also dedicated and taken the decision or pathway to deliver as soon as it is not dangerous to the woman, you deliver. If you can deliver within a reasonable amount of time, you deliver. If the woman is not stable, you stabilize and deliver, right? If you cannot give regional anesthesia, you make sure that the platelets are high, you transfuse this and you deliver, right? So once you have diagnosed that, we don't come back, will it be all right? No, because you are putting the woman in danger. So you have to have protocols in your unit to diagnose severe preeclampsia, and then that pathway, there is no going back. You don't go back and now, okay, it settles, we will wait. No, she will fit and she will die. Okay, so therefore, remember, if you have started this protocol, you have started the IV antihypertensive, you have started the Magsalfate, you are on the pathway to delivery as soon as the mother is stable. You do not reverse back and think that she will be all right. Okay. Any place for aspirin in pregnancy-induced hypertension? Well, aspirin should be prophylactically started initially because it will help in the trophoblastic invasion, right? So therefore, I think we covered this comprehensively, 150 milligrams starting after 11 or 12 weeks, right? Especially in women who has risk factors or has had pregnancy-induced hypertension before. Yes, aspirin is indicated, 150 milligrams. Can MRI be done for pregnant mothers? Yes. Initially, the MRI is not indicated in the first 12 weeks. It is thought it can cause problems for the baby. So initial first 12 weeks, we don't do MRIs, right? Unless it is absolutely indicated. But later on, we can do MRIs. And remember, we are doing the MRI for the brain, okay? If we are looking at fits and we are suspicious that there's a intracerebral hemorrhage, right? So that can be done. Same dose is given for neuroprotection in different emergencies. Yeah, same dose. It's just exactly the same as the eclampsia protocol. If we start Magsalp in preeclampsia for prevention of a seizure, does it mean that we must deliver within 24 hours? It's not. There are no hard and fast rules. If we start Magsalp, we are thinking of delivery. We deliver as soon as possible. Only thing we can slightly hold off is for our neuroprotection to work and the, if necessary, to hold off a bit for our steroids to work for the baby. But normally, we try to deliver as soon as possible when the mother is stable. Okay, it need not be 24 hours. Okay, right. Right. Okay, I think we have answered all the questions. Does anyone else have questions? Okay, so you all are very bright children. So I think enough for today, right? So, okay. So I think we have completed hypertensive diseases in pregnancy, right? Now I've done chronic hypertension, I've done preeclampsia, I've done eclampsia. So we will revisit the emergencies in obstetrics at a later date anyway. But this is something that I want you all heads to be, clear about the principles of the management of preeclampsia, impending eclampsia, and eclampsia. Okay, right. Okay then. Good night.
Good night, sir. Thank you.
Good night.
Good night, sir.
Thank you.